right. So my name is Chelsea, and I am one of the forensic nurse examiners at University of Colorado Hospital here in Aurora. We service Anschutz Medical Center, the main campus, and we also service Highlands Ranch Hospital. I have no financial disclosures tonight. So our objectives this evening, we're going to define what a forensic nurse is and our principles, the EMS objectives and pre-hospital considerations, specialized screening and examinations, and demographic and epidemiology considerations as well. The first couple screens, we're just going to go through some definitions to kind of have an understanding of a few things, and then hopefully have some fun with some of these slides and learn some things. So what exactly is a forensic nurse examiner? Most people ask us if we're SANE nurses. SANE does fall under forensics. Forensics is the umbrella. So as a forensic nurse examiner, we see all patients who are affected by violence. So that would include sexual assault, child abuse, elder abuse, intimate partner violence, strangulation, physical assaults, gunshot wounds, stabbings. We see a variety of different assault patients. And so SANE is actually specifically for sexual assault nurse examiner. We are registered nurses, not doctors. We have received specialized training, quite extensive specialized training in the provisions of this type of medical care. And we also partner with the legal side. So forensics is where medical and legal come together. We collaborate with our district attorneys. We testify in court as expert witnesses on the exams that we do. And we also testify as blind experts when patients don't have medical forensic exams. We are trained to perform specific full physical assessments. Very detailed. We also will collect evidence from patients and submit those over to law enforcement. It's not just pelvic exams for sex assault, but we're also going to do evidence collection for strangulation and those types of things, bite marks. And then we also help provide support to patients, referring them to other clinics or referring them to advocacy centers. We are trained to provide trauma-informed care. That's something that's very hard if you don't know what trauma-informed is or how to do that, and we'll talk more about that. And so both the Emergency Nurses Association and the American College of Emergency Physicians also endorse having forensic trained programs in the hospital setting as critical services for patients who are affected by violence. Everybody still good with hearing me okay? I'm going to take that as a yes. So just some important definitions for everyone to be aware of. So domestic violence and intimate partner violence are two different things. Domestic violence can be anybody in your home, anybody in your family, so a sibling, a cousin, your parent, maybe Uncle Bob, Aunt June. It's a pattern of abusive behavior in any type of relationship that is used by a partner to gain or maintain power or control over another in that situation. And it can be anything. It can be manipulation, coercion, intimidation, intimate partner violence. This is abuse, aggression. This occurs in a romantic relationship. It doesn't have to be someone currently romantic. However, this could be someone that you were romantic with a year ago, an ex-partner who's jealous and came back and assaulted you. We still consider that an intimate partner. Sex assault is the deliberate act of a sexual contact or behavior towards another person without that person's explicit consent. The term sexual violence is defined by the World Health Organization as any sexual act, attempts to obtain a sexual act, unwanted sexual comments or advances, or acts to traffic or otherwise directed against a person's sexuality using coercion by any person, regardless of their relationship to the victim in any setting. So we had a patient today who came in and she had had her breast touched, again, without her consent. That is a sexual assault. It doesn't always have to be penetration. So just a little bit about us at the University of Colorado Forensic Nurse Examiner program. This is a picture of our campus. So a little bit about our background. We were established back in 2017 is when we fully became a program. Our team consists of both of our assistant managers, Erin Ashman and Alexis Pleninen, and then Dr. Yanetsos, Christina Yanetsos. She is our medical director, and she's also one of our attending medical physicians in the emergency department. We are 24/7 in the hospital, so 24 hours a day, we have a forensic nurse. We have grown from just taking call in the very beginning to having one day nurse, one night nurse. We had a day nurse, a night nurse, and a mid shift who came in from 1 p.m. to 1 a.m. We now have grown in our patient population to have 2 day nurses and 2 night nurses and somebody else on call in case we. I'm sorry. I think somebody is not muted. I'm sorry. So being this 24/7 service, we are consulted. We're a consult service. We are actually consulted by a provider in the emergency department or an inpatient for any type of physical violence, such as gunshot, stabbing, strangulation, sex assault, elder abuse, child abuse, trafficking. We see everybody and we get consults constantly. We do have 2 patient navigators that we established this last year in 2024 who help with safety planning. We are able to provide lifts for patients to get them to and from places once they are finished with the medical forensic exam. We also have the capability to provide hotel accommodations for a patient if there is safety concerns. We also are engaged with over 30 active community partners who we collaborate with. Our VESPA team, which is the elder abuse team, AIM, they are our hospital prevention team, Blue Bench for sex assault, Servicios de la Raza and Rose Andom Center deal a lot with domestic violence or intimate partner violence. So we have some really great resources available to us. So how does somebody get connected with a SANE nurse or an F&E nurse at our program? So we only see people who've been affected by violence. So any individual who experiences some kind of violence or abuse or assault, so the 4 ways that we can get connected or the patient seeks help is they can engage in informal support, such as their friends, their family. Even if they're not coming to the hospital, they're still reaching out to someone for support. They can also seek healthcare directly by coming to the emergency department. Some people just go right to law enforcement. You know, they're in a state of panic. They call 911. Now law enforcement is involved, and law enforcement will actually call us and say, hey, I'm bringing a patient in. And then we'll be on the lookout so that when the patient arrives, we can coordinate with the physicians and see them in a more promptly manner. They can also engage with a case manager, social worker, or other type of support person who will also refer them to come to the hospital to see us for a medical forensic exam. So they present to either Anschutz Medical Center, a UC Health, or Highland Ranch, and then we see them and or depending on their age and what's going on, we may consult VESPA 2 for our elderly patients who are over 69. So what is included in a medical forensic exam? So we initially get a consult from our providers. We also support the patients in providing to law enforcement if they haven't already. One of the questions I ask them when we start, I introduce my medical forensic exam, who I am, what I do, let them know this is an extension of their medical care. And then some people do not like to talk to police or they're scared. And so I always preface by saying, I have some questions for you. Just because I ask you something doesn't mean that you have to do something. I just want to know what road to walk down with you. Have you reported this to police? If you haven't, would you like to? And if you would you like for me to start that process for you? And then at that time, I will step out and I will call law enforcement. We'll get that process started. And then I can also be a support person for them while they're talking to law enforcement if needed. Next, we move on to our exam. We obtain a medical history from the patient for the purpose of diagnosis and treatment. People will say, oh, you do a forensic interview. No, we are not trained in that. We are nurses, and our medical history is for the purpose of diagnosis and treatment. So when I ask patients, tell me what happened, I want to focus on the injury to your body. What did this person do to you? I don't all the he said, she said, some people like to focus on that. I want to know what physically happened to your body so I know what further assessments to provide, how I'm going to treat you. I want to know because I'm going to diagnose and I'm going to treat. After that, we do a guided head-to-toe physical assessment. Our assessments are so incredibly in-depth that we are assessing cranial nerves, the 9 cardinal gazes. We have special equipment to do these exams with, and taking medical forensic photography. We will photograph all injuries or key areas of injury. Even with strangulation, we still do all 4 sides of the neck, even if we don't see injury. We will do preliminary blood and urine testing, pregnancy, drug-facilitated crimes, depending on how long it's been since that crime happened. We can send blood, urine, or both. We do preliminary testing for STDs or STIs and give preventative medications. Also HIV prophylaxis, emergency contraception. We will collect evidence, so swabs for DNA. We will collect clothing. Maybe it's a sex assault and we collect the clothing for DNA purposes. Swabs of the neck for DNA after strangulation, trace evidence. We safety plan with every single patient. We safety plan with, what does this look like leaving here? Has this person been arrested? Is this person at home and they don't know you're here? Sometimes our safety planning includes being safe with that person, and we'll get more into that later. We do discharge planning. We don't just do our exam and walk away. Our time with these patients sometimes goes beyond their stay here at the hospital. We connect all of our patients to resources and advocates and referral services. There's many times when we are doing these exams that we call these services during our exam or in the beginning so that these resources, we can connect them either by phone. Sometimes these places that offer these resources come to the hospital to help support these patients as well. And then we also do callbacks within the first week after they've been discharged. People don't know all the discharge teaching you give them. You're not going to remember all that paperwork. You're in a state of crisis. And so we want to make sure that they're following up with the resources. Have they talked to an advocate? How are they safe? Is there anything additional we can do for them? We have a lot of reasons why we like to do callbacks for all of our patients, and we have a lot of success with these callbacks as well. Also, let me add that if calling someone is not safe because of an intimate partner, we also have the capability to email them if they have a private email address that this person doesn't have access to, so that if they're not safe, then we can find a way to reach them and still help them. So emergency healthcare interventions. The American College of Emergency Physicians, their policy states that training in the evaluation and management of victims of intimate partner violence should be incorporated into the initial and continuing education of EMS personnel. This training should include the recognition of victims and injuries, an understanding of the patterns of abuse and how this affects care, scene safety, preservation of evidence, and documentation requirements. So let's look at this a little more. The critical role of EMTs and paramedics. Hold on, let me back up. With this statement here, let me just let everybody know that not all hospitals have a SANE program for sexual assault nurses. However, every single medical provider has been trained during their training on how to conduct a SANE exam for these SANE kits. They may not be as particular or adequate as our trained SANE nurses, but a medical provider, an MD, is trained to perform a SANE exam on a patient and collect evidence. So just because a rural hospital does not have a SANE nurse or a SANE program does not mean that provider cannot perform a SANE exam on a patient. So the critical role of EMTs and paramedics. So you are the first healthcare contact in this system for this patient. You are the first point of medical care for them. This is so incredibly important. The patients, will usually be more candid with medical than they are with law. I get patients all the time who will endorse all kinds of stuff to me and then say, please don't tell the police. I don't want them to know. I haven't had a good experience with them. Patients trust you as a medical provider, and it is so incredibly important to recognize that. When you walk into a home, it's important to witness the home environment and the interactions that are going on inside, such as the pets and children, or there's substances around, weapons. This can tell us a lot about a relationship and the situation that someone is in. Assess and document injuries. Early identification of intimate partner violence may help interrupt the cycle of that violence. So do you know that there's knowledge of, like, maybe there's been multiple calls and the patient doesn't want transport? Maybe there's, the intimate partner is speaking for that patient. Maybe they're declining to let the patient go to the hospital. There's so many different dynamics that are going on in that home, and there's little signs like that give me big red flags to indicate IPV. So you have the opportunity to empower and return control of the patient, and that's really what our number one ultimate goal is in our medical forensic exams, is to give control back to the patients. When you're assessing and documenting injuries, I want to point out it's super, super important. Please don't chart any negatives. So, for instance, I've had to defend this in court so many times. Petechiae, the definition of a petechiae is less than 2 millimeters. That's just barely pinpoint. Realistically, the naked eye is not going to be able to see a petechiae. I see all the time where EMS brings a patient in, or a doctor says, oh, no oral or petechiae in the eyes. And I'm like, well, how do you know this? There's times that I find petechiae that I couldn't see with my eye. We have specialized equipment that magnifies 100 times, and sometimes until we get to that big magnification is when we see that petechiae. And so we defend a lot. Well, why did you chart petechiae, but the ambulance person didn't do it? And I'm like, well, I don't know, but there was petechiae. So try not to chart any negatives. No petechiae, no abrasions. There's 80% of strangulation patients do not show visible physical injury. It's crazy to think about, but it's true. Some of my most critical and sick patients have not had any visible injury. So also, as time goes on, you may not even see injury until 48 hours later. So it's very important. Do not chart no petechiae or no abrasions. Just so hard to defend in court. But do chart the obvious yeses. Is the patient having neck pain? Do they have a cough? Are they short of breath? Those things are important, because some of those things will also resolve by the time you get to the emergency department. We've had a call where a patient called and said, I've been choked with people say choked, but that means strangulation. It's very important to educate people on that. Choking is the inward choking through the trachea where something is stuck, where strangulation is pressure from the outside, including the airway, including the veins and all the structures in the neck. So it is very important to document those signs and symptoms that you see for the purpose of diagnosis and treatment, because a lot of those symptoms also can resolve by the time you get to the emergency department. So those symptoms are important to document. So people victim blame a lot and don't even realize it. So why don't you just leave? Well, without intervention, violent episodes tend to reoccur and increase in intensity. Victims may attempt to leave multiple times before they perceive they're safe and able to establish resources. And then there's also power and control, fear of losing their health insurance, institutionalization, no access to medical care, control of finances. I get that all the time. People say, why don't you just leave? Had a neighbor works for the Denver DA's office and said, I just don't understand why this woman won't just leave. You have to understand, most of these situations, he controls the finances. Maybe she doesn't work and she stays at home with the kids and she has nothing. If she leaves, where is she going? He pays for the house. He makes all the money and has control of the bank accounts. What about their family? Is the family going to be accepting of that? What am I going to do to my children if I leave? So in their eyes, it's easier to stay. It's not just easy to leave. It is proven that the most dangerous time for a victim is when they actually do decide to leave that relationship. So we have to be very, very careful of when we help people leave when they're finally ready. It is very, very common that we may see someone in my emergency department and do a medical forensic exam on this patient a dozen times. That's not an exaggeration, for the same assault or strangulation by the same person before they actually are able to leave that person. So some pre-hospital considerations for you. Recognize warning signs of an abusive relationship. Interpreter use. What if a patient needs an interpreter and their partner says, no, I'll do the interpreting? That is a red flag to me. What if the partner is not allowing the patient to answer their own questions? They're not allowing the patient any privacy. These are huge red flags because that partner needs that control. A critical role where victims may not understand danger and they're reluctant to seek medical care to implicate their attacker. People are super reluctant to get anyone in trouble. Even the worst assault victims that I come in contact with will say, I just don't want him to get in trouble. Oh, he's not that bad of a person. I just don't want him to get in trouble. Victims minimize their injuries because of either lack of education or understanding regarding what happened, regarding the severity. Your role is so critical to be able to educate these people about their safety first and foremost. The biggest thing that we focus on is safety. They are super reluctant to share information on the assault, especially in front of the abuser. So if you can separate those people, it's so incredibly important. You're probably going to get more information that way. And then ask questions that are pertinent to injury evaluation. Leave the details of the assault to our team to avoid re-traumatization. I've seen patients who come in and EMS gives us this long, detailed history, things that weren't even pertinent to them, just being nosy. And then the provider says, well, tell me what happened. And they have to tell their story again. And then we come in and I'm like, okay, so let's talk about what happened. Let's focus on the injury to your body. And the patient says, I've already told everybody. Can't you just get it out of my chart? We have a specialized training to ask particular questions in certain ways in order to be non-biased and it's for our diagnosis and treatment. So all the questions that you would ask a patient should also prioritize diagnosis and treatment. See, what else? Did I miss anything? Oh, one of the questions you can, which is really important, is, who did this to you and where are they now? That attacker might be around the corner waiting for them. So prioritize safety first and foremost. So often people do not have any injury. 80% of my strangulation patients have no visible injury on their neck, but yet I've had blunt force trauma injuries to the arteries in their neck, but you see nothing visible externally. Non-fatal strangulation is a strong predictor of future homicide and violence. If somebody if somebody's hands are around your neck one time in a non-fatal strangulation, you are 7.5 times more likely to die by their hand the next time. Strangulation should be encouraged. All strangulation should be encouraged to be transported for medical evaluation, even if it's just for a few seconds. It only takes seconds for someone to lose consciousness, which then results in TBI. Even if there is no loss of consciousness, we still evaluate for traumatic brain injuries with all strangulation patients. Prioritize the airway first with that cerebral blood flow, consideration of a cervical collar application, and then use gloves. Please, 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 please use gloves. If somebody has had somebody else's hands around their neck, that is pertinent DNA that we are going to collect. Avoid cleaning the neck. Don't dress wounds if you can help it, unless they are bleeding out and you need to gain control, and that's what's important. By all means, please do. But preservation of evidence is a must. All right, traumatic brain injuries. Goodness, this is such a big one I see all the time. A TBI, as we all know, it's just an umbrella term for many, many things involving the head. So there's things like sports injuries, strangulation, whether it's hypoxic or anoxic. Of course, I'm sure you all know anoxia is loss of oxygen, hypoxia is decreased oxygen. So non-fatal strangulations, even though some of them are anoxic, majority of them do not lose consciousness, so they are hypoxic. The more traumatic brain injuries a person experiences, it affects the time for the brain to heal. And repeated brain injuries can also affect somebody's personality. Maybe somebody just credits their injury, or they're inappropriately laughing, make inappropriate comments, they're not able to rationalize. These are all indicative of multiple traumatic brain injuries. It's like a medical sequela. All these things that are listed here on this screen, chronic pain, depression, TBIs will alter somebody's personality. So now are they, have multiple STDs because of different choices that they're making that they weren't making before. Chronic abdominal pain, sexual dysfunction, pregnancy, all of these things can also be a result of a TBI based off of the personality change that somebody has. So even if somebody has a head injury, whether they've been hit in the head or they've been strangled and lost consciousness, even if you do not see visible injury, still please encourage transport to the hospital. IPV is very complex, and it can lead to lifelong health complications. So safety planning with these patients, the sooner we can safety plan with them and educate them and get them to safety, it will decrease healthcare costs, because they're not coming in with these multiple TBIs, and then you see all the other diagnoses that it can lead to for different reasons. So it'll decrease healthcare costs in the long term, and also decrease long-term complications. So hope that makes sense. Is everybody doing okay so far? I can't hear anybody. I'm assuming you're all in the chat. Yes, yes, yes. Perfect. I love this. Okay. Perfect. All right. I hope you guys are learning something. This is fun. Okay. So here's something to consider. The patient called and they said this was for abdominal pain. Realistically, many of the calls you're going to get that involve intimate partners are not going to be called in as my partner is abusing me. We had, okay, let me back up. Evaluate every call, every patient, and where there is a need for law enforcement involvement. You all probably know your scene safety assessment, patient safety assessment. Police officers state that intimate partner violence calls are one of the most dangerous and unpredictable calls that they actually have. Treat the scene as an attempted homicide. Law enforcement is there. Call them if there's concern for scene safety. EMS should treat all calls the same way. They're all dangerous and volatile when it comes to intimate partners. So don't hesitate to return to your ambulance, discuss options for safety, and then notify police and secure the scene. Um, this is so crazy. I can't tell you how many times we've walked down our emergency department because the partner is outside with a gun and threatening our staff. So a couple of examples. I got a call, or I had a trauma page come in. A lady jumped off the third balcony and broke both of her legs. And so I went in and I thought, well, is this a suicide attempt? Is she need a behavioral health consult? That's what came through. Somebody jumped. Anytime somebody usually jumps, you think suicide. Well, come to find out, she jumped because she was having a domestic dispute with her intimate partner. Her phone had accidentally called her mom. Her mom heard it. Her brothers went over to protect her. As her intimate partner opened the front door, he started shooting her brother. And the only way out of that apartment to escape was through the balcony, and she jumped. So that was an interesting one. There was also a 911 call where a patient said that she was choked and that she couldn't breathe. Dispatch ended up asking her if she had a history of asthma and then put the call through as an asthma attack. So you can get any kind of call. Always just be aware of, could this be something more than that? If you receive a call and this is a female who is less than 40 years of age and she has any type of stroke-like symptom, I would ask if there is partner violence, because more than likely that is what has caused this symptom, and that is the real reason for transport to the hospital other than what they called you for. So just something to keep in mind. Females under 40 with stroke-like symptoms. Not everyone, but I would say that I would be very surprised if you asked the majority of your under 40 female patients with stroke-like symptoms and they don't tell you that it's not intimate partner violence. So medical forensic exam. It is a specialized F&E assessment in our evaluation. So let's go over these a little bit. Strangulation. We collect a strangulation history. Once we get through all of our assessments, we collect a detailed history for diagnosis and treatment. Then we go specifically into a strangulation assessment. So how many times did this person strangle you? How did they strangle you? What's the manner and method? Ligature, chokehold, 2 hands from the front, from the back. We have an 8-pack diagram where people can look at it and point and tell us this is how they did this, and that becomes part of our photography. What's the duration of what each strangulation attempt? How long did it take? Did you lose consciousness? Some, people when they lose consciousness, they don't know that they did. I don't know if you guys heard a couple of years ago about the Aurora police officer who assaulted a disabled lady. She was my patient. She didn't know she lost consciousness, but I asked, were your pants wet? Afterwards, did you notice that the crotch of your pants was wet, or that you pooped in your pants? And she said, oh my gosh, when I was at the other place, I was putting napkins in my pants because I was wet down there, and I just thought maybe the road was wet where I'd been laying. She lost consciousness. So it's how you ask your patient, rather than, did you lose consciousness? No, but were your pants wet? Well, yeah. So that can change the course of everything. And then the amount of pressure, we always ask, can you rate it from 0 to 10? 10 being the hardest pressure you've ever felt and 0 being nothing. And this really helps us understand for the patient's perception of how severe that strangulation is. Signs and symptoms to look for: vision changes, their voice, dysphonia or voice changes. Patients will say, well, my voice sounds really raspy. Memory issues. Can you remember what happened? Is there a period of time that you don't remember? Maybe somebody tells you, oh, I was in the bedroom when this started and I woke up and I was in the living room. Well, that's a good indication to me that there was some loss of consciousness. Are they having any difficulty swallowing? Any difficulty swallowing, painful swallowing, coughing, headaches, the bruising, pain? Of course, you're not going to be able to see petechiae. And if you do see something, it's more than likely a petechial hemorrhage, even though it still looks really small. So we're going to do a neurological exam, looking at all 12 cranial nerves. Dizziness, the acoustic nerve is damaged if they're still having dizziness. Any of that dysphonia, the voice changes or the difficulty or painful swallowing, those are all part of the cranial nerves as well. We're going to do some medical forensic photography. So we're going to look at the eyes with our special equipment, and we do our 9 cardinal gazes. So we're looking at all the areas of the eye, trying to look in the eyelids, all around, just trying to get to the back of the eyes, looking for any signs of injury above that level of strangulation. So if somebody has petechiae or has been strangled at the base of the neck, you could expect to find injury of the petechiae and things like that at a level above where that strangulation occurred, because that's where that blood flow was cut off from, above that area of strangulation. We'll collect evidence as needed. We're going to swab all sides of the neck where they told us that the strangulation occurred. So if it was a chokehold, and I might swab all 4 sides of the neck. If it was from the front with 2 hands, I'm going to do bilateral and anterior neck. And then we'll palpate after we've done our swabs for evidence collection. Even though I said, wear gloves so that you don't contaminate DNA or evidence, realistically, even gloves, like, we really don't even want you touching the neck, period, because what if that DNA transfers onto that glove and now you've taken that glove off and thrown it in the trash? So just be very mindful. Diagnosis and treatment, I can't say it enough. If there's something very serious and you need to palpate, fine. Like, we're not going to get mad, but just be aware that the DNA or the transfer of DNA is so easy, and it's very easy to lose as well. So we're going to do the eye and oral photos. So oral also, we do the insides of the cheek. We find injury a lot of the time. We're looking at the frenulums and the gums and the upper and lower lip mucosa. I've found petechiae behind the uvula in the throat before. So we're looking for all those visible signs as well as the non-visible signs too. And then we're going to do our alternate light source, or the ALS light, with photo documentation as well. An easy way to put it is that it's more like, it's kind of like the black light. You see on TV where they spray luminol and then they shine a light and it brights up. Well, this is a little bit different. We have 2 different lenses, a yellow and an orange lens that we put on a camera, and we look at all 4 sides of the neck. And what we're doing is we're looking for different levels of absorption of the hemoglobin from the blood. So just because somebody doesn't have any visible injury externally on their body, we're still looking under the surface to see if we can find any areas of discoloration that might be consistent with a bruise underneath all that tissue. So when you do find something, it's actually pretty cool. And I mean, you can't call it a bruise because you can't see it on the outside, but most of the time people say it's tender. So we always say that it's probably consistent with the bruise from that strangulation. So all this diagram here are all different symptoms that signs and symptoms that people can have that we address everybody for. I mean, we're looking in the scalp for petechiae, bald spots from hair being pulled. Are they having ringing in the ears? You can have petechiae we look in the ears. Chest pain, chest redness, maybe they were sat on or suffocated in that way. Even chest pressure, somebody sitting on you and making you feel like you can't breathe, that is considered suffocation. So let's see, someone, even if they're not coughing, but they're constantly like clearing their throat, they can't get that frog out, that's indicative of strangulation as well. So traumatic brain injury, these are so common. So the ACE concussion evaluation was put together by the CDC, and we use their guidelines. So there's a symptom checklist. You can get a possible score of up to 22. Per the CDC guidelines, even a score of 1 can indicate a traumatic brain injury. However, that's not always the case. We look at physical findings, cognitive, emotional findings, anything that's sleep related. We also look at protracted loss and recovery. We look at those risk factors. So that means that we're going to ask people if they have a history of having traumatic brain injury. There's history of learning disorder, history of headaches, history of anxiety or depression, history of any mental health disorders, because all of those things take place in the brain, and those things are going to indicate that it could take a longer time for you to recover from a traumatic brain injury, if that makes any sense. So we need to do a lot of teaching with increasing this awareness and in our discharge instructions and how to care for oneself, because I had a little boy, he's probably 8 at the time, whose dad strangled him. Um, and he came in a week later. Mom didn't know about us, and they told her to come in. And I did end up seeing petechiae in his mouth and his ear, which surprised me because I would have thought that it had reabsorbed by then. But I went over the traumatic brain injury screen, and he kept saying no to everything. No headache, no nausea and vomiting, nothing like that afterwards. And I thought to myself, wow, does he remember he's 8? Does he really remember if he had those symptoms? Well, then we got to the sleep disturbances and the cognitive um, risk factors, and he was saying yes. And so I signed serious bodily injury for a TBI. And, a year and a half later, his mom is still calling saying, his behavior is changing. He's getting in fights at school. He's picking on people. He's not the same kid that I knew, because his brain has been exposed to multiple strangulations over time, having multiple repeated traumatic brain injuries, and it's taken him a long time to heal. And so it's changed his personality, unfortunately. Um, so even with these traumatic brain injuries, we have to do a concussion screen with all strangulations because of the lack of oxygen during that strangulation. And we also do it with any head injury that we get. If somebody comes in from a bar fight and they've been punched in the head, we're doing a concussion screen. Somebody falls and skins their nose on the sidewalk, but they're like, no, I didn't hit my head. I'm doing a concussion screen and eye and oral photos because it involves the head. So we do photos of all head injuries, also of the eyes, of the mouth. And then if we need to collect evidence as appropriate, maybe there's a bite mark on the cheek, still going to do a concussion screen, going to collect those swabs for that possible saliva, going to take my photos and assess for a traumatic brain injury. If there is loss of consciousness with this traumatic brain injury, they were punched and maybe someone's punched in the head or in the face and they lost consciousness, then I'm probably gonna sign serious bodily injury, and then that's gonna be a mandatory police report. Anytime somebody doesn't want to report, but they meet SBI, it is law that I have to report that serious bodily injury within 24 hours. So let's say a patient comes to us with intimate partner violence and they're in a really dangerous situation and they do not want to report whatsoever. I can't report, he's going to kill me, I can't do this, I can't do that. But they meet serious bodily injury. By law, I have to report that. So I tell my patient, look, I have to do this. They can know your name and date of birth, and that's it. I have to report it, but for safety reasons for you, I'm going to wait till you leave the hospital. I have 24 hours to do this. Once you're gone or first thing tomorrow morning, then I will call and report this and they'll know that you're gone. And that's how we get around that in order to help keep our patients safe. Let's see, sexual assault. This is, goodness, a really detailed history. We need to know if it was a partner, if it was the household member, like who's the person that's done the assaulting. We always assess for drug facilitated sexual assault. That's when we do like the preliminary blood and urine testing. We can do prelim results at the hospital for I think 12 different like Benadryl, fentanyl, cannabis, those types of things. The crime lab tests for way more stuff. So we'll still send it off, but we do our preliminary testing. If there's suspicion for drug facilitated sex assault, we always do sensory questions. Did you hear anything different? Did you feel something? Did you taste or smell or see anything? All of those sensory questions sometimes will trigger things in people that they had no idea of before. It's an incredibly interesting assessment to do. We're still going to do a head to toe exam. I've seen someone assaulted and they had fingerprint bruise marks around their thighs. Of course, our pelvic exam, which requires an additional consent, evidence collection, and medical forensic photography of all the pelvic areas as well. We are going to test for sexually transmitted infection. We have guidelines to how far out from the assault we can give prophylaxis and HIV medication and emergency contraception. We provide all of that in our exams. And then we're also going to call our advocates in, like the Blue Bench, who deals specifically with sexual assault survivors. And they're going to come in and they're going to continue walking this road with the patient after they leave us. I've had a patient who was still working with them 2 years later, and they were paying for her mental health and counseling to help get through this sex assault. And then they do offer services to come to bedside to be an advocate for that patient. So, and then we also do the safety plan, other referrals if appropriate. We always tell people about victims' compensation and reporting options. So we'll get into reporting options here in a minute. Let's see on the side here, the Blue Bench. It talks about people can say a rape kit. That's also a sex assault kit. It is typically 5 to 7 days. I think the guidelines for CDC maybe is like 5 days. However, we collect up to 7. Sperm can live inside the pelvis for, I think, 21 days. And right underneath that cervix is a real good hiding spot for it. And so when someone comes in and we do that pelvic exam, we swab the heck out of from underneath that cervix. So, and the sex assault exam, depending on everything they endorse, can take anywhere from 2 to 6 hours from beginning to end. So let's talk about intimate partner violence. This is what I see the most of. And again, an in-depth history. We're going to do more assessments for these people. So we really, really focus on a danger assessment, which is, it's a validated tool. Jackie Campbell created it. And you can have a score anywhere from 0 to 39, and it's going to assess the risk of lethality in that relationship. So this is only validated for men who are abusing their female partners. And we asked all kinds of questions. You can even Google it and look it up, danger assessment. And we're going to ask questions like, does he own a gun? Has this person ever threatened you with a lethal weapon? If so, was that a gun? Has this person forced you to have sex when you didn't want to? Does this person threaten to kill you? Do you believe this person is capable of killing you? Has this person ever attempted or tried or threatened to commit suicide? Do you have children that are not with this person? Have you been beaten by this person while you were pregnant? All of these questions, and depending on the number, gives us a risk of lethality, and then we're able to do additional safety planning on top of that. We also do this thing called the power and control wheel over here on the side. And when I give this to people, I ask them, read through here and see if anything on here applies to you. If it does, circle it, just circle that whole thing. This helps us understand the dynamics of this relationship. I had a patient recently who it wasn't even physical. He was more emotionally and financially controlling to the point it was pretty bad. And she saw this by using this power and control wheel, and she has actually gotten away from him. He ended up causing a huge scene with the gun outside after all of that, and she is still in safety with her and her kids, and they're doing really well. So this power and control wheel is a very powerful tool. On the other side, we'll flip it over, and it's called equality. And it has all these same themes, but it shows what a healthy relationship is supposed to look like. And funny enough, people will always circle all the things on the power and control side, but not have anything on the equality side. It's actually very, very sad. So we have specialized advocates specifically for this patient population. We still do the same thing, head to toe assessments, photos, evidence collection is needed, referrals to outside agencies, victims agencies, and then we support for law enforcement reports. And then a lot of these patients, we're having to collect all the information on all the children in the home because we are mandated to report to CPS as well. Sorry, I know we're kind of getting a little shy on time, but we're not far from being done. So child abuse. We see patients of all ages. If there's a child with a sex assault and they are prepubescent, then take them to children's because we cannot do a speculum and those types of things. But we will see all patients. We may ultimately just decide to send them to children's, but over there they have what they call the child protection team. You'll just call and ask to be connected to them, and they have their SANE nurses over there. Anytime we have someone who comes in with child abuse, we do a pediatric caregiver assessment. This is going to tell us, we want to know all the children and everyone who lives in the home, because we want to report this and make sure that all the children are safe. If this child, if it's a sex assault and this patient is under 18, it is a mandatory law report. We do an in-depth history one-on-one with that patient. We don't want that pediatric patient to be influenced by anyone, not friends, not parents, not advocate. I mean, nobody. It is specifically one-on-one. We're still going to do our head-to-toe assessments, our photos, evidence collection, mandatory reporting, and resources. All of our assessments are the same, with the exception of just the extra specialized assessments that we do with each and every patient. These pediatric cases are pretty hard sometimes. They'll just say, grandpa touched my cookie. Well, what is a cookie to you? Oh, well, that's down there. Well, what is down there? Can you tell me? What is that called? And so we go through a lot of trying to get to their language and documenting that so we can show how we have been non-biased, but we did not assume just because a patient used a slang term. Elder abuse. This is also in-depth history from the patient and the caregiver. We do a caregiver screening, just like we did the pediatric screen. We have different things like the Elder Abuse Suspicion Index, what's called the EASY. It's 6 items to assess elder neglect or abuse. Just because it's abuse doesn't mean it has to be physical. It can be spiritual abuse. It can be financial abuse. And those 6 questions are over here. Have you relied on people for the following? Bathing, dressing, shopping, banking, or meals? Has someone talked to you in a way that made you feel ashamed or threatened? Have you been forced to sign papers? Those types of things. And that will help us determine if this is neglect, if it's abuse. Our VESPA team, our elder team, also gets involved. We collaborate with them and work alongside them a lot. If a patient is over the age of 69, this is also a mandatory law report. I don't have a choice. I have to do it. And sometimes it really is a drag because the family is like, we're doing the best we can to care for them. I'm like, well, I get that, but that's not up to me to decide. I just have to do my mandatory stuff, and I'm still going to care for your loved one, but the police are probably going to show up just to make sure that everything is safe at your house. So resources are huge here. Our VESPA team actually will continue to collaborate with the patient outside of the hospital and help set up resources for these individuals. Human trafficking, we don't see a ton of it, but these patients, I mean, we do see human trafficking, but it comes as they come in with different complaints. And so we recognize red flags, whereas other healthcare providers do not. I think there was a statistic, I'm probably going to get this wrong, but like 60 or 70% of patients who are victims of trafficking had encounters with healthcare providers or someone in the medical field who never even recognized that they were being trafficked, which blew my mind that it was that big of a number. But we ask questions about autonomy. There's 18 specific ones about their living conditions. Are you able to come and go as you please? Are you allowed to keep a hold of your documents like your ID, credit cards? Do you have access to food and water? Where do you sleep? How many people sleep in your home? And these people aren't very forthcoming. They're the ones that are going to have their so-called quote unquote cousin in the room with them, but it's a completely different nationality, or it's someone who's young, like their age, and also has a phone on speaker and the trafficker is listening, or if we separate them, the trafficker has to be on the phone. There's a lot of red flags. You're never actually able to separate these people. And so a lot of these trafficking patients go right back out there. It's interesting because they're very vulnerable. You think, well, just walk away from your trafficker, but you can't, because they're the ones providing them a place to live. They're the ones providing them with shelter and food. They're the ones that provide their clothing. The traffickers are the ones who provide everything. So if they leave, they have nothing. And one of the big telltale signs when I walk in a room and somebody's feet are dirty, it's usually bruising, because that's how they will beat them, is on their feet, so that you don't see those markings on their body. So something else to be aware of. So data and numbers, this is towards the end, and then we'll do some questions. So interesting things to think about. The most types of patients we see are sex assaults, strangulation with traumatic brain injuries, and intimate partner violence due to the strangulation also. So you can see this is from 2018 to 2024. Strangulation and TBI are correlated together there. And you can see how the numbers have gone up every year. Into 2024, we saw, let's see, we had 2,221 patient encounters, but we did exams on 1,222. And following that is how many, 827 had a TBI, 502 of those were strangulation. Down here, 307 were intimate partner violence. So we are seeing a big number of patients who are coming in with these diagnoses and concerns. It's you can see the human trafficking down here, 26. It seems like it's almost nothing. Elder abuse, 43. So our numbers, our highest numbers are, like I said, the TBI, strangulation, sex assault, and intimate partner violence. Relationship to assailants. So one of the big things to take away from this is that the partners, most likely people are being assaulted by their intimate partner, by their child's parent, or previous, like I said earlier, previous intimate partner. So you can see the numbers speak for themselves. 2,298 people out of all of these were by their partner, ex-partner. It's just really sad that that's what we see in relationships these days. It's so common, more common than you realize. And it's hard to put into words or to make sense of it, because I don't understand it. But we're here to help them. So also going back to this, something to be aware of when you go into these homes or these scenes. A lot of them will be staged. I don't know if this is something you've talked about or training you've had, but a lot of these partners will try to stage it as a suicide. That maybe they hung themselves, but really they didn't. They staged to look like that. Just be aware of your surroundings at all times. I don't know if you heard recently about the new California law called Joanna's Law. We'll talk about it. It's a Senate Bill 989. They just passed it this year. This legislation mandates that law enforcement officers have to thoroughly investigate deaths that are suspected to be suicides, especially if there's a history of domestic violence in that home. So the background is Joanna Hunter. She was killed by her intimate partner, but he staged the scene, and they ruled her death a suicide in less than 30 minutes after arriving. And then 13 years later, we have this law. It took them that long to reverse that and realize that something was not right. So the objective is that the perpetrator stages the scene to be a suicide scene or drug overdose. And then they've come up with 10 factors that they have to go through prior to concluding this death investigation. So these are the 10. Did the person die prematurely or in an untimely manner? The death scene appears to result from a suicide or an accident. One partner wanted to end the relationship. The history of being victimized by domestic violence that included coercive control. The person is found dead in a home or a place of residence. The person is found by current or former partner. They have a history of being victimized by domestic violence that included strangulation or suffocation. The last person to see this person alive was their child, their partner, or their previous partner. Partner had control of the scene before law enforcement officer arrived, or the body was moved or other evidence moved in some way. So all of these are red flags where they have to investigate as a homicide and cannot rule it a suicide, which I found very interesting. And then, one of the things that when reading all this that they did talk about was that the more of these factors that exist, the more likely it is to be a homicide. And it's mostly primarily suffocation or strangulation, which doesn't surprise me. So, and then location of where most of these take place, most of these assaults, obviously in the place of residence or that person's primary residence or a home of a friend or family. Very rarely do we see them coming in from a hotel or a park or something. I mean, we see it, but it's mostly in the home, in the bedroom, in the living room, over the couch, those types of things. These are the reports that we've gotten by year. So with sex assaults, people can choose to either report to law enforcement or not report at all, or they can do medical or anonymous. The state of Colorado does hold sex assault kits for up to 20 years. That's how long a patient has to change their mind from an anonymous or medical report to being law reporting. So that's a whole nother can of worms to talk about at a later date when we have more time. But there are reporting options for sex assault survivors. And even if somebody doesn't want to report, we will encourage them to be anonymous. Law enforcement doesn't know anything about this person, no name, no date of birth, no nothing. That it's all there's tied to it is a case number. So that way, this person, since we only have 7 days to collect DNA, at least if 6 months from now this person processes what happened and says, I want something done about this, then we've got that evidence and it's not too late for them to go through that process and get that justice. So most of our patients do report to law though, but the anonymous is always a good option because of that. With the medical reporting, law enforcement can know who you are and you can have your kit tested. However, it's not like a law report, and you don't have to talk to law enforcement at that time until you're ready, even after the results come back. And if it shows something and you want to change the law reporting, then you can. So it's a little confusing at first, but once you get the hang of it and what all these different reporting options mean, it actually makes a lot of sense. So some guiding principles: treating patients with dignity, respect, and compassion first and foremost, with sensitivity to their age, culture, ethnicity, and sexual orientation. DV, domestic violence, is unacceptable in any type of relationship. Their presenting complaints can be anything from a headache to dizziness to abdominal pain, anything. There's nothing uncommon. The process of leaving a violent relationship is often long and gradual, and it requires carefully developed safety plans. It's not just easy as walking away. Your goal with these patients is to help them. The goal of trust within healthcare, long-term continuity of care, and then support them through the process of attaining greater safety and control of their lives, helping them do that, and then ensure safety of the victims and their children is priority. Most of these people won't seek help because they're afraid their children are going to be left behind or hurt, and so finding what's important to them and also addressing those matters as well. So why should you care? Interesting question. I thought that a long time ago. Why should I care? This isn't happening to me. Well, funny enough, men who strangle women are the most dangerous on the planet. And it is so common. It is so scary. 68 to 80% of all women will experience near fatal strangulation in their lifetime. And then in 2017, officers who were shot more in IPV calls than any other calls that they responded to. And then victims of prior attempted strangulation are 7.5 times more likely to becoming a homicide victim. And I have seen this happen. All right, so one last thing here. I know I keep saying that. Cop killers, we've all heard of them. So in Riverside County, the DA's office, they did a study back in 2013 is when they completed it. It was from 93 to 2013. They looked at all the law enforcement officers that were killed in the line of duty. So 50% of the officers were killed by criminals with public record history of strangulation assault against a woman. 50% of those officers, of the 50% of the officers who were killed, it was by someone who has a previous assault on their record of strangling a woman. 90% of the cases of those officers who were shot, 90% of those people had a history of DV. 50% of them, children, were present, and 99% of the suspects were men. So it's, to me, those are some pretty big numbers that just very alarming. So just some funding for care. The Colorado Safe Fund reimburses us for sexual assault kits. Patients, we bill their insurance or self-pay for, they're still responsible for their actual ER bill. We do provide medication vouchers from the hospital. So if a patient has HIV prevention medication, we'll go through insurance first, and then whatever's left over, we will provide a voucher so that they don't have to pay for that 28-day prescription. And then victims compensation is a payer of whatever's unpaid above, but it is compensation. So if your outstanding hospital bill as a result of this crime, it has to go through all the other channels first of, insurance and things like that, discounted billing, and then you submit to victims compensation and they can compensate you. So, and then the Colorado Project, this is a grant that was offered through the Department of Criminal Justice. So this is to ensure that anybody statewide can obtain this education for sexual assault and forensic education. There is a program phone that you can use. Here's their email. And then they also have after hours technical assistance if you have questions or if you need help navigating a difficult situation, or if there's a provider who is needing help performing a SANE exam. These are some numbers that they can call in order to get help with that. And then just know you always have the opportunity every day to change a life. So this is our phone number to our forensic nurse examiner program at UC Health. That is the phone number to the forensic nurse who is on duty and is carrying that phone. So if you have any questions, need some clarification on something, or just want to connect with us, then please reach out to us. We're more than happy to share whatever we can with you and help you with anything that we can. We're pretty passionate about what we do, and just want to ensure that safety is priority, especially when it comes to strangulation. We don't like seeing people in these awful situations. So any questions? Man, I talked a lot. Sorry. Deborah, you are so welcome. This was so much fun. I really enjoyed this. What do you recommend doing in a rural area with an assault? Taking them to local ED and requesting that they are transferred to UC Health for a more thorough SANE exam. So if you have an assault victim, I would recommend your local ED depending on where you're at. I assume you're not close to where we are. Like I said, every medical doctor has been trained to do a SANE exam. We have gotten patients from facilities for a higher level of care where they've come to us just for this exam, which to me seems interesting because all medical doctors have been trained during their residency. So I would start with your local ER and at least make sure that the patient medically is okay. And then we can talk, you can call us, consult with us, and we can talk more what a more thorough exam looks like. Learned a lot. Thank you. Y'all are also welcome. I know there's probably going to be more questions as things come up. Give us a call. We're happy to answer any questions, help with resources. We have our two patient navigators who also are great at finding resources in other areas. We had a nurse who came to us. She was assaulted by her partner, and somehow something happened where her granddaughter may have been being assaulted, and they were in another state. And our amazing navigators actually found some resources in this other state for this family. So nothing is too much. We tackle hard things every single day, and we deal with a lot of vicarious trauma. We all have therapists, so bring it our way. We're more than happy to jump in and help any way we can. Anybody else have any questions? Does everybody know what serious bodily injury is and what that means in signing SBI forms? Does anybody want to know? So just real quick, police will bring in a form and say, does this person meet SBI? That means serious bodily injury. So bodily injury is like scratches, bruises, sprains. That's bodily injury. Serious bodily injury, it addresses injuries that have serious and potentially lifelong consequences for the victim. So I sign mostly for traumatic brain injury and strangulation for hypoxia or anoxia. It's a legal term that it helps define how that serious bodily injury was met. So there's certain stipulations. So it's a substantial risk of death. Well, strangulation is a substantial risk of death. Permanent disfigurement, maybe somebody has like a huge gash to their face and they have this big, they're getting stitched up, or I've had an ear bitten off, or I've had someone who had their partner tried to shoot them and they had shrapnel covering their face. That's permanent disfigurement. Even if it's a gunshot wound to the abdomen and they have a huge wound vac, that's going to be permanent disfigurement. Protracted loss or impairment of a bodily function, TBI, for sure, because of the brain function. I've had a patient standing on the side of the road who was hit by a car and his foot was amputated. That met protracted loss or impairment of a body or body part or function. Second or third degree burns meets it, any fractures or breaks, and then penetrating gunshot wounds and penetrating knife wounds. So if somebody comes in as a trauma and we are starting mass transfusion protocol, substantial risk of death. So there's a lot of things that you can sign serious bodily injury for. And realistically, what that does is anything that might be a misdemeanor, it turns into a felony. So, and the QR code for CEs, I need to check on that because my medical director is out of the country. And so I took this over for her. So let me ask her and I will find who I need to find to follow up with that. So I apologize that I don't have that answer for you. Any other questions for anyone? I think we have about 11 minutes unless you all want your time back. Ah, perfect. Yes, yes, Ryan would know also. I'm glad you all enjoyed this. It's very interesting to me. It keeps me on my toes, always learning. And so I get really passionate about things like this. And I know people are just like, holy cow, you're coming at me with a lot of information. But man, this is just something that's so in depth and so intriguing that I want to educate everybody. So thank you all for being patient and listening for a whole hour and a half to me. Oh, thank you, Deborah. All right, well, I guess I will give everybody their time back tonight. Have what, 10 minutes? Go enjoy some time with your families. And I appreciate you all being here. Thank you.